Good evening, ladies and gentlemen. Welcome, and thank you very much for your valuable time. Just conscious of the fact it's the evening, and obviously, once again, things are changing ever rapidly. Obviously, the Prime Minister's made further announcements today, which we'll look forward to hearing more about. And obviously, some of those measures that are coming in will help people with practices. I'm conscious that we are aware of the fact there's been a bit of a downturn in some general practices, and I think some of the measures will be of benefit. So I think next week, once we see the legislation, we'll organise a call with relation to what they might mean for general practice. But here today, we're here to do a COVID update with Professor David Wilkinson. So for those who may or may not be aware, David is his master's in epidemiology at Cornell, the United States, specifically focusing on infectious diseases. So has unique knowledge and skills, and is once again a participant in the government briefings, etc. So definitely, as far as somebody that can help disseminate the information that's coming through and put it in a meaningful form for us. So, David, can I pass over to you?
Thanks very much, Paul, and good evening to everybody that's on the video conference. And as always, it's a great pleasure for me to join in and contribute to our understanding of this extraordinary pandemic. As Paul indicated, just very briefly by way of background, by training, I'm an infectious disease epidemiologist. I have what some people would consider a morbid curiosity about this particular pandemic, and I'm following it in excruciating detail through my position at the university. As Paul said, I'm part of a group that is being briefed directly by chief health officers around Australia as we do a lot of work at university level to react to this situation. So it's a pleasure for me to try and share with you some of the key stuff that's going on. What I'd like to do is just spend hopefully no more than 10 minutes to give everybody a quick update on the pandemic, particularly as it applies to us in Australia. Try and understand what the heck is going on and how it is affecting all of us, and then leave the rest of the time for your questions. So at a high level, I mean, things have changed massively in the week since we did our first webinar this time last week. Amazing how much can happen. And there are now over 4,000, around about 4,000 cases in Australia. In New South Wales, where I am, we have the largest burden by far. Almost half the cases are here. Because of the size of the population, but also because, of course, most international travellers arrive in Sydney, and we have the dubious honour of receiving many cruise ships, and lots of sick people have been coming off those cruise ships into New South Wales. In the world now, we're well over 650,000 cases and 30,000 deaths. There have been, I think the latest number of deaths in Australia is so far very small, thankfully, 18 cases, I think, and I think 9 or 10 deaths now in New South Wales. The epidemic is growing, obviously. There are more and more cases, and that is completely to be expected. What's important to appreciate is that the very large majority of these cases are imported cases. These are travellers who have returned to Australia or the contacts of those travellers. So certainly more than 2/3, if not 3/4 of these cases fit into that category. There are a small number of clusters of contacts of these people, and then there are a small number now of community transmission cases in Australia. What is really interesting is that the number of new cases is stabilizing. Now, it's too early to say at all, much too early to say that the epidemic is coming under any control. But there is a feeling amongst chief health officers that the interventions put in place 2 weeks ago in Australia are starting to show effect, and that's encouraging. So the epidemic curve that we are seeing as we plot the number of cases each day and the number of cumulative cases is starting to level off. Again, it's not the end at all, but the pattern we are seeing is the pattern you want to see at this stage. We all saw over the weekend the additional restrictions on movement, social distancing, etc. It will take another 2 weeks for the full effect of all of that to come into play. But there is a sense that what we are doing is starting to work. The borders are now effectively closed, as you all know. People who return to Australia now go into mandatory quarantine for 14 days. That means there will be no new imported cases into Australia, and the health authorities now have a chance to identify all of the cases, all of the contacts of those cases, treat and isolate those people, and the effort is underway now to minimize community spread. It's important, again, for us all to remember why all of this is being done, why the social and economic upheaval is happening. And it is simply because if we don't do this, and if the epidemic in Australia goes anything like it is in Italy, for example, the health system will just be completely overwhelmed, and we will not be able to treat the number of people who will get sick to such a level that they need hospitalization, ICU, and ventilation. So it's quite interesting. What I'm being told for New South Wales is that the capacity for ICU beds and ventilation has now doubled and quadrupled respectively. The health system is gearing up for the anticipated possible very large number of very sick people. So again, without any sense of the work is done at all, there is a sense that the right things are being done and positive impact is being seen. I'm asked all the time, how long will this last? The answer to that question, of course, is nobody knows. I'm working on the assumption that we will be in the sort of position that we're all in now for at least a month. It really needs 2 to 3 weeks to see how good the changes that have been made are. We'll know that in 2-3 weeks time, and then there is the possibility, if case numbers are falling, that the authorities may move to loosen some of the restrictions. Now, the problem, of course, is if they do that too early or too much, there's a risk that the epidemic blows up again. That's the simple reality that is going to be faced with. So I'm assuming that we will all look like this for at least a month. It could get more severe lockdown for a period of time. And then you would imagine some form of restrictions for several more months. So at the university, we are assuming a month like this, 3 to 4 months, something like this, and many months of restrictions around social distancing, etc., etc. So just as an example, at Macquarie University, where I'm Deputy Vice-Chancellor, and this is the same now in all Australian universities, all teaching is completely online. We have completely turned around our business model in 10 days. And we don't expect that to change anytime soon. Just an example of the huge changes that are being required here. Just to wrap this session up, and then I can see there's a number of questions being posed. We are expecting more testing Australia is doing a lot of testing. There are many tests being evaluated by the TGA at the moment. I believe it's 15 or 16 different tests. We would expect many of those to be approved very quickly and made available much more quickly. We need to test more and more people, obviously. Case detection and contact tracing and isolation is really important. There are many drug trials underway around the world, testing currently available drugs, repurposing them and seeing if they work for COVID. And there are at least 30 vaccine trials planned and registered, some underway. There's a small number of vaccine trials that already have candidate vaccines in people doing safety testing. And it's quite fascinating to see the speed of action in the scientific and medical community. The final thing I'll say for GPs and general practices, clearly massive upheaval. Again, it's extraordinary, as we heard over the weekend and clarified today, that now telehealth is essentially available to all people in Australia, all GPs in Australia. I mean, how many of us thought that was ever possible? Clearly a range of important changes in our work practices in clinics around safety and protection of our staff and protection of our patients. As the Prime Minister has made clear, as the Principal Medical Advisor to the Department, Professor Michael Kidd, has made clear, general practice is at the forefront of this response. Absolutely essential work that is going on, and not just in responding to COVID and potential COVID cases. And again, there are only 4,000 in Australia at the moment, or have been. That's plenty of cases, but it's not massive yet, and let's hope it doesn't become massive. But they're all very keen that GP services continue. General practices are completely essential services. They want us to use the telehealth items as much as we can, because of course that limits the interaction, the face-to-face interaction. It's a really good way to socially distance. But the Prime Minister and the Health Minister, Minister Hunt, and the Principal Medical Advisor, Michael Kidd, all make it very, very clear that face-to-face GP services of whatever type are vital, they're essential, they need to continue as best they can. So, Paul, I might stop there. I hope that's been a useful overview of the epidemiology of the epidemic, a sense of how long this might last for, and at least an opening on the impact for general practice. And very happy to take as many questions as we've got.
Beautiful. So, ladies and gentlemen, down the bottom of your Zoom frame, you'll see a Q&A box, which you are welcome to put questions in, and I will obviously try and filter them and pass them on to David. So, I mean, I suppose one of the questions you got, David, and I'll just go through them. So, how will I diagnose, I suppose, COVID without rapid response test kits or laboratory? I mean, is there any other method?
Yeah, so I think the testing criteria are changing all the time, and they started with quite a restricted criteria to allow testing, simply because there weren't that many tests available, and they had to start with the high-risk cases. They're expanding the case definition for testing quite rapidly. My view would be, if you have somebody that you suspect may have COVID, that you direct them to a facility that can do COVID testing. They are setting up respiratory clinics in different parts of the country through the primary health networks. There's one just down the road from me here in North Sydney. I would direct patients for testing to these primary care respiratory clinics. I wouldn't be doing it myself. However, these new tests, the rapid tests that are soon to be available, offer obviously a very different route for methodology, we need to see what the TGA authorizes, and we need to see whether these are diagnostic in the acute phase of infection, or whether they're diagnostic, after infection. So I think it's a case of a lot of that will become clearer this week.
And I mean, so how many tests are needed to confirm full recovery?
So the current situation is a nasopharyngeal swab for diagnosis that will shift into a blood test with IgM and IgA antibodies. At the moment, the recommendations are around symptom recovery, and depending on the patient's status, whether they need to show absence of viral load. So again, this is why I would recommend that suspect cases are managed through one of the specialist respiratory clinics at this stage. The caseload is low enough for that to occur.
Okay, I've got a few questions here around obviously various drugs that could be used to treat the virus. I mean, are you aware of any drugs that are currently available that can be used?
Yeah, so there's quite a lot of interest in a range of drugs. There are some quite interesting case reports coming from around the world as doctors try different things. There's quite a bit of interest in chloroquine, particularly in combination with azithromycin. The advice in Australia, which I would strongly recommend that we follow, is that these drugs should not be used outside of the hospital setting. I think it's our responsibility as GPs to identify patients at risk, patients with possible diagnoses, get them diagnosed, and then if they are sick enough to warrant hospitalization, and let's remember, 80% of people will have mild illness or no symptoms, and there is increasing evidence that many more people are asymptomatic. There's only a small proportion require hospitalization, and trials are underway, and the hospital-based specialists will try these drugs out in a controlled hospital setting.
Awesome. So can we give clear advice to patients about quarantine or self-isolation? So what is the recommendations we should be saying?
Yeah, certainly. So the 14-day rule is the good rule of thumb. Where does that come from? Well, we know now quite clearly that the average duration of incubation is actually 5 days. So, some people get symptoms really quickly after infection. Others, it takes a little bit longer. And the 14-day period is essentially a guarantee. So if you are exposed to somebody with COVID and you go into self-isolation, then you have no symptoms within 14 days, you are not infected. So the 14-day rule is the one to hold on to. I know a number of people, I have a number of colleagues and friends who are in self-isolation, and that's the protocol that should be followed. Of course, for returning travellers before the weekend, they were under strict self-isolation, and now for returning travellers, it is mandatory quarantine again for 14 days. And essentially 14 days is a guarantee that if you have been exposed and you get no symptoms in that time, you are not infected.
Okay. Question around CPAP machines working as ventilators.
Yeah, well, they're trying a whole range of things at the moment, and my attitude here is let's hope we never have to get to that situation. There are something like 2,200 ICU beds in Australia, or there were before COVID. All health departments have been working hard to double that capacity. I know that has occurred in New South Wales. and to quadruple the ventilation capacity. So you can ventilate a patient without having them in ICU. So if you think roughly 4,000 ICU beds, roughly 8,000 ventilators, that's a lot of capacity. And if we do everything that we're all doing now, we won't need it. So this is all about buying time to make sure that we don't need it. I haven't looked at the numbers for New South Wales today, but when I looked at it yesterday, I think we had about 10 patients in ICU and 3 or 4 of them were on ventilators. So hopefully we won't have to get into that sort of desperate setting and situation. There have been stories in the press today, you know, that the vets are giving up their animal ventilators for human use. That's fantastic, but if we get to that kind of position, then all of the self-isolation and all of the quarantine and all of the border restrictions have not worked. And all of the intent here is to make sure that we have a situation with coronavirus whereby the people who do require hospitalization, and it's about 20%. So, you know, if you looked at round figures for Australia, 4,000 cases, right? So maybe 800 require hospitalization, but it's only 5% require ICU care, right? So it's only a few tens of patients might require ICU and then ventilation. So hopefully we won't get anywhere close to needing all of that additional capacity.
Okay. So in workplaces, people with a travel history within 14 days are told not to come into the building for appointments. Should the contacts of those people who have travelled also be told not to attend?
No, it's a great question, and the answer is no. So obviously, this is all about levels of risk, and you know, prior to the weekend, returning travellers were asked to self-isolate, and they were trusted to do that. Again, I know a number of people that have been doing that, and the cops have been checking on them every day, interestingly, sometimes in person, knocking on the door, sometimes on the phone. So that's fine. Contacts of those people, it's safe to consult with them. And the same is true now after the mandatory quarantine. And essentially, of course, with mandatory quarantine, there are no contacts in Australia of those people.
Okay. So Canada would seem to be the most comparable to Australia, with, I suppose, the exception of not sharing a border with the US. Is there anything we can glean from their situation, or maybe from other countries?
Yeah, I think there's a huge amount we can learn from all around the world. So there's a number of different things going on, right? I mean, Hong Kong did an amazing job. Obviously, a border with mainland China. You know, there was every risk that Hong Kong would have been swamped with COVID. It did not happen. I know Hong Kong very well. I go there regularly. I have many close friends up there. And Hong Kong had something like 100 cases. And why? Because they closed the border and they did strict case identification and contact tracing. And it's a small country, right? However, they now have 400 cases, and that is from returning travelers into Hong Kong. So Hong Kong has now shut its borders again, this time to all incoming travelers. That's a key lesson. Singapore's done a very similar thing. Singapore, a very orderly society, lots of preparation from SARS and MERS. They went early. They did the same thing, case identification, contact tracing, etc. They've now had an uptick in cases, and again, it's returning travelers. So they've closed the borders essentially. The UK went too late, and they run the risk of being swamped. The US went way too late and had very poor testing. They are only now doing stay at home in the last few days in some places. Very, very significant problems, I think, emerging in the US. New Zealand, very interesting. They went straight to level 4. So middle of last week, they closed the border and everybody is staying at home. Very strict social distancing. And that strategy aims at epidemic suppression. They are going hard and fast to suppress the epidemic. You can easily imagine, with no new cases coming in, that they can very quickly get to the situation of no or little local transmission. The problem then is, when do you open the border? Do you keep a closed system for how long? So I do know that the chief health officers in Australia are paying very close attention to everything that's happening all around the world. The intention here is to control this epidemic as much as we can, to not have the health system overwhelmed, so that we can treat those people who do get seriously ill. And as we've all seen, this has caused massive social and economic disruption, and the government is now trying to minimize the impact on that.
Another question. So are skin excisions essential?
Yeah, so we've had a few questions about skin cancer clinics and skin cancer services. They're definitely essential in terms of the government's regulations around all of this. All health and medical services are deemed essential. That's very clear in the government's press releases. If you also look at the law, and the law on these issues occurs at state level. You'll find them in the state government gazette. It's very clear: all health and medical services are essential and should continue. There is no reason or justification for any general practice care or service to be closed down, slowed down, withdrawn. I would certainly be using the telehealth item numbers as much as you can. But again, as the Prime Minister, the Health Minister, and more importantly, Professor Michael Kidd, the Principal Medical Advisor, keeps saying, you know, in general practice, we need to do a lot of face-to-face consultation, and we should do that whenever we need to. And the key is just protecting ourselves, our patients, and our staff as we go about doing that. But they are definitely essential services.
Okay. Is it possible to recover the disease once infected, and is it recurrent or not?
So nobody knows, right? Because we're too early in the epidemic. But the view from everybody that knows about these things is that once you've had it, you will become immune and you are very unlikely to be reinfected. That is the opinion from the expert immunologists and virologists and infectious disease people. So we expect immunity to occur and to be quite persistent. But, you know, we have to wait and see.
Okay, beautiful. So one question around the use of, I suppose, all the hand sanitizer use. I mean, is there any risks you can be charged with DUI from excessive sanitisation?
Now, look, I think we're all getting used to washing our hands a lot. And, you know, it's interesting that when we do come through this thing, whenever that is, I rather suspect we'll all be really good at washing our hands, and so we should be. And I rather suspect we'll all become very good at social distancing. And in future flu pandemics, you know, I think we're likely to see, you know, fewer cases, just because we all take a lot more care about those really important personal and professional hygiene practices. Yeah.
So another question: is it not true that the only clinical trials of treatment sanctioned by the WHO to do with antivirals only, not some of the other medications touted in the press?
No, there are multiple clinical trials of many different medications underway. They don't have to be sanctioned by WHO. WHO is running one very large trial, but there are multiple trials. For anybody that's interested in that, you can look at the clinical trial registries, All clinical trials are registered, and there are multiple trials underway testing different antivirals and other things.
Okay. How infectious are asymptomatic patients?
Yeah, well, it's a great question. So again, the honest answer is we just don't know yet. What is becoming clear is that this thing has a very wide spectrum of symptomatology, ranging from no symptoms at all, through to very mild symptoms, through to, pretty severe flu. And then, of course, hospitalization is due to a viral pneumonia, and then acute respiratory distress, respiratory failure, and death in some cases. So that's the sort of disease spectrum. I think that there is more and more evidence being published to indicate that asymptomatic patients carry the virus. We know that's the case. If you're carrying the virus, you will be shedding the virus. How much? Who knows? So my view is asymptomatic patients will be infectious, but they will be of limited infectiousness. So if I have no symptoms, but I'm carrying the virus, I am much less dangerous to you than if I'm symptomatic and coughing and sneezing and puffing and blowing. So in the short version of that is, it's just like any other viral infection that way. Okay.
So what's the stance legally with medical certification requested by a number of bosses to allow workers that have the UTI and not swabbed back into the workforce? So people that do have the urinary tract infection.
Well, I would only issue a sick certificate. I understand the pressure that colleagues get put under, but I would only be issuing a sickness certificate if I was completely sure about the criteria that I was issuing them for. And I think that if you feel that it's inappropriate, then just try your very best to resist the pressure that's going on you in that regard. I mean, the reality is, at this stage of this epidemic, anybody with upper respiratory tract symptoms needs to be considered to have or be at risk of having coronavirus. So if you have upper respiratory tract symptoms, you should be at home self-isolating until those symptoms go away.
Okay. There's a few questions related to this, and I think you may have answered the question, but once again, I'm sort of reading and listening at the same time. So it's around how many tests needed to confirm full recovery? Do we need to retest after 2 weeks in positive cases? And how long a period can we wait to recover once infected?
Yeah, so the simple answer there is if anybody tests positive, then once they are asymptomatic, they would be considered non-infectious. And you don't need to retest them.
Okay, awesome. And what sort of chemical cleaning solutions should we be used for cleaning?
Look, I think the standard disinfectant around the place is quite adequate. Whatever you normally use in your clinics or your household is quite adequate. This is not a special virus. It does last for hours or even days on different surfaces. So certainly keeping surfaces clean. Some practices are, doing the benches and the common surfaces every hour, that kind of thing. That's the way to go. Just use the advice on the health.gov.au website.
Yep. And I suppose some of these are comments, I suppose, but I note that the testing criteria up to this point require travel or contact. Does that not distort the figures, just the amount of community spread?
It definitely distorts the figures. They've recently widened the criteria now, But in terms of having an idea of how many cases there really are out there, absolutely, that's correct. So we can be pretty sure that we're capturing the deaths from COVID. Of course, anybody with anything like COVID is being tested. So we know that number. But there will be many more cases than we have tested. There's no doubt about that. I did look at the numbers earlier today, and there is there are hundreds of thousands of tests have been done, and the prevalence of infection at the moment is about 0.2%. So, and it has to be lower than that, because as the questioner rightly says, we are biasing the testing towards symptomatic patients. So the prevalence in the community is really, really, really low at the moment.
And what's the sensitivity and specificity of COVID testing? I mean, how confident can we be that a negative is actually a true negative?
Oh, I think very confident with the nasopharyngeal swab. That is PCR test, so has incredibly high sensitivity and specificity. I mean, as we all know, nothing is absolutely 100%, but that kind of testing is as good as it gets. We'll have to see what the rapid tests do. But the TGA is going to approve something that they don't reckon is working the way we need it to, and we will all see that data before we start using the tests.
Okay, just a few more, then we'll be done. Oxygen concentrator can be used at home or not to save a patient's life.
Difficult for me to think of a scenario when you might need it, but if you have an acutely distressed patient and who needs oxygen, then yeah, whatever it takes, right? We do know that some patients progress very quickly with their symptoms and their course of illness. But I think, if we've got somebody with acute respiratory distress, they need oxygen, we would use whatever we had while we were waiting for the ambulance, right?
Yeah. And just with reinfection rates, obviously China's the early leader in this, and there's obviously been some media reports around a 13% reinfection rate. Have you got any information on that?
Yeah, I haven't seen that data. We know that there are more and more cases coming into China, but again, they are returning patients. I haven't seen data on previously infected patients becoming reinfected, but certainly we are seeing a second wave of infection in China, the same in Singapore, the same in Hong Kong, and you would expect that to happen in any country until we get herd immunity or a vaccine. That will always be a risk. The key thing there is working to make sure that the number of cases in the second wave is quite low, so that the health system can treat those patients who require it. It is worth just mentioning here, in terms of putting things in perspective, I was looking at some numbers over the weekend out of interest. In the United States, each year, 55,000 people die from flu. Okay, 55,000 people a year in the US die from flu. In Italy, where, as we all know, COVID is causing terrible trouble, they have a very significant problem with flu most years. And in a bad year, in Italy, they can have up to 43,000 deaths in a population of 60 million. So, the intent with COVID is to get the numbers well below the numbers of flu. That's what everybody is trying to do here.
Okay. Beautiful. All right. Well, thank you very much, David, and I really appreciate everyone's participation today. I know we're gone 10 minutes over what we're meant to. But look, the goal is that every week we're going to be doing an update. As I said, it's rapidly changing and obviously new papers being published every day. And we'll obviously appreciate, David, your time for disseminating that information and sharing it with us and answering the questions. So I want to thank you for your time and thank everybody for participating. And just a reminder on Thursday, for those of you that own medical practices that may be going under a little bit of a challenging time, we've got a gentleman by the name of Alan Milt, who's a world expert in managing cash flow. So we have a webinar on Thursday evening where he'll be going through and showing how to manage cash flow. And he's also got a great online web tool, which you can basically put 6 numbers into it and it'll map out your cash flow for the foreseeable short term. So it's definitely, as the challenges, come, because, ultimately if we have patients who don't want to come in, and yes, we're going to be doing bulk billing teleconsults, but it'll be interesting to see what the take-up rate is. And also, we have to bulk bill those services to be able to access those item numbers. What impact will that have on a practice? So if you are a practice owner, I would suggest you would be very wise to join us on Thursday evening. Otherwise, we'll be back at this time next week with David's further update. So thanks very much for your time today, David.